Assalamu alaikum warahmatullahi wabarakatuh. I welcome everyone on board. Uh, we will just try to have a revision of some key concepts about ICU. Um, okay, so actually there are certain common points about ICU management. So first question will be ICU patient assessment. Like you have a patient in ICU. What are the common things by on the basis of which you evaluate the patient? Yes, Waqar, how will you assess the prognosis and assess a patient who is admitted in ICU? Like, for example, we say the patient is on ventilator.
Sir, generally we assess the from analgesia, bowel care, catheter
Directly
line.
analgesia? Directly analgesia?
No, sir.
So why you are taking so saying analgesia? A, B, C, D, E.
Airway, breathing, circulation.
So how will you assess? What about GCS? What about lines? What about medications?
Ji, sir.
Okay. What about general nursing care?
Fast feeding
So,
and
so you,
antibiotic.
if they ask you a question, would you like to start only with analgesia?
No, sir.
So please improve your answer, please. You can go system wise, whether the patient, for example, what about neurological assessment? Neurological assessment, like what you guys GCS, AVPU, and at the same time whether the patient is receiving some sedation, paralysis. Okay, so this is the first thing you can say. Okay, whether the
Right.
patient is whether the patient is like what's the neurological status. Okay, so you can neurological status you can assess with GCS, with AVPU, what sedation is going on, what UL sedation patient is receiving.
Mostly, sir, if you're on vent, then it is midazolam and
Fentanyl, propofol. Okay, and dexmedetomidine. By the way, now there are ICU ventilators who are having vaporizer. Okay, so they have the capability of delivering the inhalational agents as well. So it's also a possibility. So this is sedation. Now, like you will be assessing the GCS. Like anything else in the neurological system, would you like to see
muscle power, sir.
muscle power? You will assess the sensory, motor,
Sir.
and autonomic. Okay, so and reflexes, autonomic system, and also reflexes. Usually, sensory and motor. If the patient is intubated, the assessment will be in a different way. Sensory will be difficult to measure. Okay, and unless the patient is responding to you, so reflexes can be measured. What else?
Reflexes like, sir, pupillary reflexes and
Pupillary reflexes and peripheral reflexes, like motor, this ankle jerk or knee reflex. Like all reflexes can be evaluated. Okay, and it will tell you not only the like outcome, and your like for example, if there is a concept of sedation break, so you can also evaluate this thing. Okay, so with reference to respiratory system, how will you evaluate? Because actually this question was asked in the table viva. How will you
Yeah,
assess the cardiovascular system of a patient in ICU? This was not written anywhere.
sure. By
It-
the breathing pattern, maintaining maintenance of adequate
You know,
oxygenation.
yes, oxygenation and CO2. Whether it
Sure.
is whether it is mechanically ventilated or like BiPAP or spontaneous. Okay. Like oxygen, usually ICU patient will be receiving oxygenation with the nasal cannula or face mask or non-rebreathing reservoir bag or what else? Venturi, and now these days high flow nasal cannula. This is the
Or
way
like,
you are giving. Huh?
right.
You are, what you are giving. If you are talking about ventilator, so mode, what mode? Minute ventilation and tidal volume, respiratory
Any sub.
rate, PEEP, both peak airway pressures and
Yeah.
plateau pressures. Okay. And then FiO2 you are giving. This is all what you are giving. And how will you see whether the patient is responding in the form of PF ratio? Okay.
ABGs.
ABGs, very good. Or chest X-ray,
Sure.
ultrasound. Okay. CT scan. These will be like any like in examination, you will find some things. Auscultation, percussion, inspection. So examination and objectively with PF ratio, ABGs, chest X-ray, ultrasound, CT scan. That's how you evaluate a patient. Okay. And that will be telling you about ARDS. That will be telling you about like high ventilator settings or low ventilator settings. How much is PEEP? How much is FiO2? You want the minimum FiO2 to get maximum PO2. Okay, that's your aim. You want minimum PEEP. You want adequate respiratory rate. You want adequate tidal volume. Okay, you want you don't want more airway pressures. Okay, you want good chest X-ray. You can evaluate whether the patient is dry, whether the lungs are having any edema or pneumothorax or anything like that. You can also with the ultrasound you can also see the level of tube. So these are the things which you can get. It's CT scan, of course, in high further if you are evaluating. Okay. So of course there are some investigations which are not being done in ventilated patient, but usually this is how, if someone asks you how will you evaluate, so oxygen you are giving and CO2 you are washing out and you are getting the PO2. That's how simply you get your results. So now come the CVS. So how will you evaluate the CVS?
Maintenance of blood pressure,
Blood pressure, heart rate,
normal heart,
sinus rhythm. Okay. What else? If you
uh,
are talking about cardiac output monitor or cardiac output monitoring, you
good
will see
good
the
perfusion, good perfusion with urine output and capillary refill.
very good SVR. And just a few words about this cardiac output, lung, extra lung water. Okay. And cardiac output, cardiac index, pulmonary. So these are the parameters you will be getting through this thing. And of course, blood pressure, maybe it is invasive or NIBP, heart rate, sinus rhythm, and then as you mentioned about circulation. Okay. Circulation will be with the signs of poor capillary refill or cold phlegmy Okay. You measure the urine output. And there is one more thing which is telling you about the perfusion, lactate levels. Do you tell? Do you tell it? Do you tell about it?
No, sir, I missed.
So lactate levels are also part of your cardiovascular exam. I know that I'm giving you an insight in a different way. So once you do it, then you will come to know how will you apply this in all your management, whether it is ARDS, whether it is sepsis, whether it is VAP, whether it's so basic things are the same. Okay. So
Right.
lactate levels will tell you, and then what else? ABG is also part of ABG is also giving information about your cardiovascular system. And of course, here also the physical examination, signs of poor circulation, cyanosis, clubbing, all the general physical examination will always help you. Okay. And any murmur, again, ultrasound can help you. Chest X-ray will help you. Bedside echo or T. This is how you will assess any system in do we miss some investigations not only there in respiratory system, also in respiratory system, and the investigation we missed. So in investigations, cultures are very important with reference to respiratory system. So culture of not only blood culture, sputum culture, endotracheal tip culture. Okay. So the cultures will also be helping. And here, not only this one, then some cardiac enzymes. Okay. Some parameters of cardiac failure. What are those? Like ANP, BNP. Okay. So these things will also help you out. Of course, other investigation you can also correlate like CBC. You will correlate with hemoglobin for the oxygen carrying capacity. Also, with reference to respiratory system, you want your WBCs to be on the lower side, not like high, because it will be a sign of infection. And then all other liver function tests or renal function tests, they are directly or indirectly correlated with actually all the system. Also, if you are thinking about liver or kidney, so you will assess. There will be some things which are, yes, lactate will tell. So in cardiovascular, because main systems are cardiovascular system, respiratory system, and rest of the things are going around and around. Okay. Of course, when you are thinking about it, then your kidney function will be tested. So with reference to kidney, of course, with the respiratory system or cardiovascular system as well, but edema will be a feature. If the kidneys are not functioning well, then your renal function tests, and then urine RE and culture. Because in bedridden patient, in ICU patient, urine infection, UTIs are also a big source of patient going in sepsis. Okay, in addition to, of course, the ventilator associated pneumonia or other thing, but this is also a hidden source. Okay. Okay. So now another very important thing, like there was ventilator there, here what will be that whether the patient is maintaining spontaneous blood pressure or heart rate or rhythm, or the patient has any vasopressors or inotrope or diuretics, antiarrhythmics. That's part of your evaluation. Like if the patient has blood pressure, mean blood pressure of 60 or 80, without any support or with support. So when you are explaining, even these tips will help you even in your case presentation in ICU as well. That how are you, Jennifer? Can you just mute your mic, please? Your, yes. So that is how you even explain your patient, present your patient in the ICU as well. So this will help you that whether vasopressors, inotropes, okay, diuretics, antiarrhythmics, So these are the medication which spontaneous FIPFU ratio without any support or with support. Okay. Then the rest of the things you can tell everything in the assessment. What I will divide it in homeostatic assessment. What do you mean by homeostatic assessment? Fluid, blood gases, and electrolytes. Okay, O2 and CO2. Usually these are the and of course the blood parameters. So blood indices, that fluid balance intake output is good. The blood gas status is good. Electrolytes are good. CO2 is good. O2 is good. And blood indices with reference to like CBC or platelet count or okay. When you are talking about fluid, the assessment will be the nutritional assessment. Okay, Zishan, can you tell me how you assess the nutritional status?
Sir, we can assess the nutritional status first on the basis of history. We will ask about the patient, any symptoms of patient of any symptoms patient of having malnutrition, such as excessive vomiting or refusal to eat, loss of appetite, and any loss of sudden weight, uh, basis of the history. And after history, we can do a systemic examination, general physical examination, in which we can assess the body weight of the patient, muscle size, muscular loss of muscular size of the patient, and all the systemic examination concurrently with it, sir. And then we can also assess the lab investigation, in which we can see if the patient has any anemia, anemia like any blood distance. We can also check the albumin levels, electrolyte levels. These can be on the basis of history, examination, and investigation, sir. We can
Yes,
assess the
like
patient's
yes,
nutrition status, sir.
also individual vitamins, because when you are talking about nutrition, usually we are talking about carbohydrate, fats, this proteins, okay? Then the vital nutrients these are, and then also vitamins. So in maybe
Right.
assessment in the same way, whether the patient is losing weight, whether the patient is muscle mass is going down, blood urea nitrogen nitrogen balance, patient is going in negative nitrogen balance. So this is very important part of the nutritional assessment. So that's why an ICU patient should start the nutritional support at the earliest possible time. Okay, that's another question, that how will you assess the requirement. So exact method is calorimetric method. Okay, and usually how you give around 20 to 30 kilocalorie per kg. Am I right? How you
Yes,
assess
sir.
the this is the baseline, and then you add this is the basal energy expenditure. And when the patient is sleeping, no other stress, then the resting energy expenditure, which will be multiplied by 1.2. Okay, and then what the next step will be, the stress factor. Okay, so mild stress, intermediate stress, or severe stress according to the level of stress that the patient has. So you will again multiply it by 1.2 to 1.4 to 1.8, things like that. I'm just giving you a rough idea. Then what will happen, like for example, if you calculate the total calories are, for example, 3000. Okay. So now you will divide it. You will keep protein as zero point 0.5 to 1.5 gram per kg proteins as a caloric free. You will not calculate proteins in the out of these calories. You will divide these calories into protein as fat and carbohydrate. Am I right?
Yes, sir.
So around what you will do, 40 to sorry, what do you say, 50 to 60%, 60% through fat and 40% through carbohydrate, or I'm just missing it?
No, sir, opposite, sir. 60% through
Carbohydrate,
carbohydrates, yes, sir, and 40% to lipids.
60% carbohydrate and 40% fat. Okay. And then what you will do, you will make this 4 to 1 formula for basic fluid requirement, and then you will take divide it according to the calories. Like if you are taking 50% dextrose water, or you are taking 10% of this lipofundin. Okay. So you will calculate the rest of the volume. Whether it will be enteral, we will see the article of it to see the remaining part. But I just told you there and then. So whether it will be parenteral nutrition or enteral nutrition. Okay. And preferable is enteral nutrition. Okay. If a patient cannot take enteral, then you will go for parenteral. And this will also part of nutritional assessment. If the patient is taking through enteral route, how will you assess, Zishan?
Sir, if the patient is taking through the enteral, then patient will have a tube such as nasogastric tube or orogastric tube. Then we
Or
can check or
gastrostomy tube.
gastrostomy
Gastrostomy
gastrostomy tube.
or
Yes, sir.
jejunostomy tube, feeding jejunostomy also. Okay.
Yes, sir.
So aspiration, you do the aspiration. Okay. So it should not be more than 100 ml. If I'm wrong, numbers, I can be wrong in the numbers, but I'm giving you the concept. So concept is you if it is coming more than that, what will you do? You will add prokinetic agent. Okay. Any prokinetic agent like metoclopramide or cisapride or domperidone you will add, or erythromycin, to increase the prokinetic. Okay. So and then you right now in spade of this one, you can measure through the ultrasound the residual volume. Okay. In the stomach. So you will assess the nutritional, this will be the parameter. You see the requirement, you see the parameters, whether the patient is going right or in the wrong direction. Then you will see, make sure how much protein needed, and then there will be some differences. If the patient is COPD, you will decrease the carbohydrates and increase the fat component. Okay. If you have a patient with the CKD, you will decrease the proteins. Am I right, Zishan? This is the basic
Yes,
concept
sir.
of nutrition. So that will be a very important component of your management in ICU. In addition to the respiratory parameters, the cardiovascular parameters, nutrition, and this is basic. We will go one by one we will see whatever things we miss. So another important component is lines. So what lines can be there? CVP, there, pulmonary artery catheter, maybe arterial line. Okay. Then drains, urine, Foley's. Okay, so chest tube, any if the patient is post-operative, like post-operative drains, any wound drains. So these are the things you have to take care, and you have to take care about the infection. So you have to do the all the sepsis bundles. So can anyone just recall what are the things with reference to lines, sepsis bundles? Yes.
Sir, is it that one in which there like proper hygiene care should be taken, hand hygiene, patient hygiene, in
Yes.
and while
You
handling the CVP, CVL line, you should wear maximum protection such as gloves, mask, face mask, gloves. You should properly sterilize the skin with antiseptic, or taking all the antiseptic measurements,
there
and
are
daily assessment.
special dressing. Okay. Like the all that I know that this question is unexpected at this time. Okay. But actually, that's how you will tune your mind. Even if they are not asking, you have to tell. The sepsis bundles will be there in any, if they're asking the management of sepsis or VAP or ARDS, these things you have to tell. Okay. So you should be knowing the care bundles for like, when they are inserting, this is one thing. And you have to make sure there is no, one, you are checking the dressing, and after how many days you have to remove it. Okay. And then you have to send the cultures. These are all part of sepsis bundle. There is a specific dressing for the lines. Okay. Another part is that you remove unnecessary line. Okay. So they are using chlorhexidine, and like, this is what you should be looking at. Okay. So what else? Then we do this fast hug. What is the formula it is telling? And they also make it fast head in bed, something like that. So F for feeding, A for analgesia, S for sedation, T for thromboprophylaxis.
Thromboprophylaxis.
So thromboprophylaxis, how you can give in ICU?
We can thromboprophylaxis. We can give. We can also like starting from early mobilization
Zishan,
to
Zishan. I wanted
yes.
to catch you and you are caught. If the first answer for this, if someone is asking about thromboprophylaxis in ICU, will all patient will be in the same category? No. So
No, sir.
you have to do the risk stratification. Which patient is at more risk? Okay.
Yes.
And then you will tell, you know the answer. Okay. But I'm catching you from a different way. So you have to identify the risks. Like if the patient is obese or patient has any cardiac problems, or like there is a list of risk factors for thromboembolism. So you have to stratify whether the patient has low risk or intermediate risk or high risk. Accordingly, you will give, because it will be starting from what you are telling. Early embolization, good fluid management, and then elastic stockings and compression devices, and early mobilization, sedation breaks, and these are all things which are actually part of thromboprophylaxis. But if the patient is at high risk, you will not stop here. You will have to give even therapeutic doses of heparin, or high dose, maybe one single dose as a prophylactic of Flaxane, or BD dose. Am I right?
Yes, sir.
So that the so it will be another, because sympathetic system is a good like is a responsible thing for all these for creation of thrombus. So you have to avoid the you have to do good analgesia, good sedation, even in ICU. Okay. So these things are interlinked. So that's what actually is. Uh, what is for H? Ulcer prophylaxis and glycemic control. What is for H? Hemodynamics.
But I think it is hypothermia. Keep the patient normal.
How do you
Sorry,
head elevation, bed?
head elevation. Okay, because I forgot the mnemonic for head elevation. Anyways, there are some other thing we will just go into the journal care, and then we will go individual VAP and ARDS and everything. Okay. So, glycemic control should be between 140 to 120 to 140, 150. It should be less than 180. Okay. And it should not be less than 100. Okay. So this is how you give insulin infusion or insulin boluses, or you are giving subcutaneous is never a good, if you have patient with poor perfusion, then it's better to give IV. Anyway, so glycemic control is important. Then few other things like what we do, hand hygiene and all the precaution, because hand hygiene is the most important thing. Okay. If you are doing prevention for VAP, so head elevation is one of them. there is antibiotic coated lines, then there is a supraglottic port for suctioning, okay, in the endotracheal tube. So that is also a part of prevention of VAP. And then the avoidance of muscle relaxant, daily sedation break, and evaluation. So these are the things by which you will be avoiding the VAP. Anything else for general ICU care? Anything I missed? Yes, posture change, and care for bed sores.
Source.
Okay. Okay. So now we go a little deep. Why patients are admitted to ICU? Mainly there are two different indications, whether it is surgical cause or medical cause. Okay. Or you can say another emergency trauma, you can say. So whether it will be a medical cause, a post-surgical, or patient has some trauma or some emergency. So so usually these are the things. So any disease you can just think endocrine problems which can bring the patient to ICU, pheochromocytoma, Addison's crisis, mixed edema, thyroid crisis. Okay. What else? Any neurological problem? Patient has stroke, patient has MI, patient has embolism, patient has pulmonary edema. So, you can just think, and you can tell. Okay. Yes, DK, honk. Like you can think, and you will make eclampsia. You can think, and each and every specialty you will think, and you will come to know that because this question is being asked. What are the reason for ICU admission? It's a very simple question, but sometimes simple questions are difficult to answer. You should be thinking. You should have an idea that what would be the indications of ICU admission. So, and post surgical, anything like bleeding, prolonged surgery, chance big fluid shifts, patient not maintaining good hemodynamics or electrolyte imbalance, this one, any neurological problem, very high on inotropes, any reason in which you are not safe to extubate the patient, like prolonged neurosurgery, and the patient, they want to relax the neurological system. They want to relax the brain, so they do elective ventilation. So these will be certain indications for patient coming to ICU. So and actually you should be knowing that what one is ICU and one is HDU. So there is a little difference. I tell many times, so I will repeat. In ICU, more than one organ support or mechanical ventilation. This is ICU. And HDU, only one organ support other than mechanical ventilation. So there is a little bit difference. In ICU, there is bed-to-bed nurse. In ICU, there may be one nurse covering more than one patient. Okay. So this is a little bit of level of care uh, in uh, in ICU. Yes, post cardiac arrest, GB syndrome, anything in which neurological, muscular, in which patient is not able to breathe, in patient has aspiration. So in any uh, pharma code patient can be admitted in ICU. What do you mean by pharma code? I'm sorry, I don't
Maybe
understand what is.
drug overdose, sir. Drug overdose.
Yes, toxicology. Okay. So toxicity. So any poisoning. So you can just think, and you know why it's important, because if you know, then you will be knowing how to manage. If you because basic nursing care and basic care will be the same. Why I started telling about basic care. So now think, any patient, if they are asking you the ICU care, or they are asking about that patient, believe me, even if they have asked GB syndrome or tetanus, your half answer is the one which I have told you. only few things will be left. So because I am a person who try to make the studies simple, because in the exam, believe me, you don't fail on big things, you fail on very simple things. So that's what I have learned through my career, that if I will tell you, haunt you by very difficult things, maybe you will not be able to, not everyone will be recalling each and every topic in the same way. But these things are very simple, very easy. Everyone knows there is a brain, there is a heart, there is a lungs, there is a liver, there is a kidney, there is a homeostatic system in which there is oxygen, CO2, electrolytes. There should be sinus rhythm, there should be good circulation, there should be good blood pressure, perfusion should be good for the vital organs. It's very easy, and you will never forget these things. If you forget even these things, then I'm sorry, we cannot do anything. But and this answer will be there everywhere, whatever topic they're asking you, believe me, this whole of the general care will be there. Okay. So like now if you go into detail into individual topics, we will inshallah, we will just have a look. Because if we just, before going, for example, if the patient has sepsis, the rest of the things will be the same. Now what will be happening in the sepsis management, what you do, you start with the fluid, you send the lactate, you send the culture, you give the empirical antibiotic. Okay. This is what you do in the start. Okay. Then what you do, and then you assess if you are able to, if there is fluid responsiveness, you will give some more fluid. If fluids are failed, and then you have take the arterial blood pressure, arterial monitoring, you have done the cardiac output monitoring. Now you might need to introduce some vasopressor. So vasopressor of choice will be norepinephrine. Okay, norepinephrine you will start. Then you will see if your heart is contracting nicely, you need to give any inotrope. So you might need to add dobutamine or epinephrine. Okay, you are failing with one vasopressor, you will go for vasopressin. Okay, so you send the cultures, and when the cultures come, you will give the definitive antibiotic. Okay. Then what you do, you check the fluid responsiveness by vena cava compression, perfusion, this focused echo, okay, and you like overall well-being of the patient. If it's not responding, then there are so many things you can do. One of them is hydrocortisone. So hydrocortisone in resistant, if nothing is, you gave vasopressor, you gave fluids, you gave inotrope, and then still, so hydrocortisone is added. And now individual things you can target, like anything separately. If the patient has anything other than this one, you will go have the separate treatment for it. Now you will have care of kidneys. You will make sure patient is producing good amount of urine. If not, if the kidneys are failing, then you will need to have CRRT. Okay. So CRT will be with reference to kidneys. If you have any blood problems, so you will make transfusion triggers for individual things. You will target a good HB. You will target a platelet count. Okay. You will look for INR or anything you need to do correct. So that is the basic care, and then the thromboprophylaxis will also come. So this is very simple way of understanding what sepsis is. And then sepsis markers. One of them is C-reactive protein, lactate. We follow with them. Okay. So that is how you will go. And then another important thing, all the vital organ perfusion pressures. So cerebral perfusion pressure, renal perfusion pressure. Okay, these are very important. You have to monitor that whether the good amount of like you are protecting the kidneys. You don't have if the kidneys are at risk, you will not give anything which is damaging the kidney. One of them is perfusion pressure, one of them is volume, and you are avoiding any renal toxic drugs. You are avoiding anything which can damage which can lead to the AKI. Okay, so there are so many reasons of AKI. So you are covering the pre-renal causes mainly. Renal cause, of course, a renal disease will be there. You cannot do much about the renal causes if it is a disease is there, but you can take care of pre-renal, and if any post-renal cause. So this is how you can like you will manage a patient with sepsis. The rest of the in the sepsis, what they ask rest, how will you evaluate? So they will ask about sepsis, um, this one, the different terminologies. What is severe sepsis? What is septic shock? Then there is one SIRS scoring. We will have a look. Um, just a second. Zishan, by the way, how to and do you know about this SIRS scoring system? And
Yes, sir. SIRS, known as Systemic Inflammatory Response Syndrome, it has three features in which two must be met, in which the temperature should be greater than 38, heart rate should be more than 90, and respiratory rate should be more than 22. So if two are met, then it is known as SARS, the patient.
okay, if because I am not doing ICU frequently, if anything I tell you out of date, please do pardon me for that, and do correct me. This was the source which I had seen. Uh, just a second. I think in
Sir,
this
I think
one,
the new, according to the new sepsis, they have removed these terminologies, SARS or SARS, and
no
they've
one,
just.
no, SIRS terminology is gone, but there is a SIRS score. One is Q SOFA, okay? Because
Yes.
there are some ICU scoring systems. One scoring systems you are doing specifically for certain disease like Renson's or pancreatitis scoring, or this one this AKI Akin. These are for specific organs. New York Heart Association or Canadian class, these are organ specific. Okay. And there are some things which you are doing for the prognosis of the patient. One of them is Apache, one of them is a SOFA. Okay. And then some scorings you are doing for what you do, this one for delirium, one for sedations, like this Ramsey scale or AVPU or GCS. So there are certain things. This is what I remember. There is SEPS because in this document they put I have not there was SIRS scoring. So you can if there is something new, you please do share with me. But because what's difference between SOFA and Q SOFA?
Sir, Q-SOFA is a rapid assessment that the patient came to you without any labs and everything, and you have
Labs
to
in them.
quickly assess whether
So this is the difference, that in SOFA, sequential organ failure assessment. So you are taking for each organ, you are taking one parameter. Okay, and you are evaluating, but some of them are laboratory parameters. So it was delaying the start of the management. So any patient with any features of QSOFA, you will start in the line of sepsis, you will send the cultures, and then you will send the labs as well, and then you can rethink about your management. Okay, so this is the this is the concept. Okay. The management things change frequently. Today, one day they are saying something, the other day they will change, but the basic concept remains the same. They only change few things. They will say we are not following this thing, we are not following this thing. Okay, but usually the basic thing will be basic thing will remain the same. Okay, and if something new, they will again. I tell you something. This is not that if they ask you something very specific and you are not able to answer, they will not fail you on this thing. Again, I can guarantee you that they will not fail you if something just has published 6 months ago and you are not able to answer. If something changed drastically, then this is not the failure point. They will fail you on something very big and very obvious. Okay. So this is what I was saying, SIRS scoring system. It's the same thing, but a little they have named it in that way. So QSOFA, SIRS, News or Muse. So News And, you know about this news and pews, early warning scores?
Yes, sir. Early warning scores.
So you should know what is the because it is with reference to blood pressure or heart rate or conscious level. Okay, is it like this? We will look. We will have a look. So I will just quickly pass through this document. Okay. Mm, Initial resuscitation, as I've mentioned to you, fluid challenge as early as possible, then reevaluation if like you are they are measuring with the physical examination, or if you have cardiac output monitoring, then you target mean arterial pressure. Uh, if you are talking generally, initially it will be 65, but if you can say that if you are worried about kidneys, you should maintain it more than 80. Okay, then the antibiotic, antimicrobials, if it is any viral origin, then maybe you can consider. You will say that we will get the help of a infectious disease consultant, and they will guide us for the proper antibiotic or any other antimicrobials needed, whether it is antifungal or antiviral. This will be a smart answer. Okay. Mm, okay. So hemodynamic management, crystalloids. Yeah, they say against the use of starches for resuscitation. They prefer crystalloids. Okay. And albumin can be given because albumin is relatively safer. Let's see whether they have written about albumin or not here, but this is the conceptually albumin is relatively safe. So vasopressor, norepinephrine, I told you, then vasopressin. If the patient needs inotrope, they will give this one, epinephrine or dobutamine. If it is right heart failure, then milrinone. I'm not sure whether it is written here or not. So ventilation, they will give the lung protective strategies. They will, we will have a look on how the lung protective strategies are being given. I'm just passing through it. uh, with land protector, usually neuromuscular blocking agents are not recommended, but if you want to knock down the patient and you are afraid of ventilator stacking and you are thinking that airway pressures are increasing, then you can consider the use of neuromuscular blocking agents only in specific scenarios. And then if everything is failure, then ECMO. Okay. IV corticosteroid, I have told you. uh, we suggest against use of polymyxin B. I'm not sure. Hemoperfusion, use of other blood purifying agents. IV immunoglobulins, they are against. Stress prophylaxis, thromboembolism prophylaxis, okay. AKI prevention, blood sugar less than 180, okay. Vitamin C against. Before they said that vitamin C is a good thing. They are also following with protein C. They were also following with procalcitonin. Procalcitonin is still there, Zishan.
Sir, they do it, but not most oftenly, sir.
Okay. Procalcitonin, no, they follow with the it's a septic marker, if I'm not wrong. Anyways, we will see.
I
So
think, yes.
yes, you were
Yes, sir,
saying
it
something.
is a septic mark.
Yes.
Yes, sir.
So bicarbonate, if the pH is less than 7.1, okay. And if you have a patient, because in these patients you will have in some scenario you will have high sodium, okay. So in this scenario, can you give soda bicarb? No. So there is another solution which I don't know the abbreviation. Its name is THAM solution, okay. So THAM solution is being used for acidosis with hypernatremia. So THAM solution is a solution, you can read about it. It's a very big abbreviation for THAM. It does not cause hypernatremia. This is one thing, and another thing is that with lactic acid, there is that specific type of lactic acidosis which is not related to hypoperfusion. So in that it respond to thiamine. Okay, so thiamine, IV thiamine is being used for hyperlactatemia. I think it is type 1A or B. You can check it out. One type of hyperlactatemia, it responds to thiamine therapy. Okay. Mm, okay. Just a second, it passed very fast. Counseling. And yes, family counseling is very important. Okay. And if the patient is in the weaning phase, then you will consider all the things for weaning. So, weaning, daily sedation, vacation, and you are trying to use medication which has less renal clearance. You don't not dependent on renal clearance. And okay, so I think this is common thing which they have mentioned here. Okay, I have now I will go to another question with reference to sepsis and then we will go move forward because this is a frequently faced scenario and they can ask you in the exam. You have a patient with sepsis, septic patient, and now the patient, this is actually a very common scenario we face in emergency. Okay, like you have a patient which was on ventilator for a long time with high inotropes, sorry, vasopressor. Now the lactate levels are going very high and there was abdominal tenderness, sorry, abdominal distension. Okay. And then the abdominal compartment pressure is high. So it is abdominal compartment syndrome. And now the patient has very high lactate level. Okay. So a patient is presented for bowel ischemia. Okay. Now they want to push the patient for laparotomy. How will you give anesthesia to this patient? Yes. Yes, Waqar, Safiullah.
Sir, can you repeat the question, please?
You are not listening? A septic patient on ventilator in ICU with high dose of vasopressors. Patient developed bowel ischemia. Okay. They want to do the laparotomy. Yes.
Then we will proceed as a high risk, sir.
Very good. High risk consent. This is one thing. Patient will already be intubated with lines.
Sir,
So you will just
move.
monitor. Patient transfer will be, sorry, patient transfer will be a challenging thing. Okay. When you are taking over, make sure you get good endorsement about the lines, about the fluids going on, about the
Lines and inotropes,
vasopressors.
draw, support.
Yes, vasopressors and inotropes going on. Even you can say that I will make sure I will get a good handover about the patient, and you will prepare all the medications the patient is taking. You will make sure you have cardiac output monitoring, or you have CVP, or you have arterial line blood pressure. So because now you need to continue the care which is being given there, and now you have to make sure the patient is tolerating the extra stress. Okay. So now the patient will be coming with severe acidosis, with high vasopressor, inotrope. So you will have a challenging. You would you like to give propofol? You want to give? No.
Likely some cardio-stable drug like ketamine and etomidate, sir.
No. Why you want to give? The patient is already intubated. You want to change the
Sir,
tube? You want to change the tube?
the patient,
No, no, sir,
the
just
patient,
for addition.
Why addition you want? There are something which is you have something which is called as an inhalational agent. You cannot give. You cannot
Yes,
continue
sir, I
with the
can give.
same sedation patient is already receiving with the muscle relaxant you
yes,
can
sir,
give.
the patient,
Okay.
yes, sir, the only sedation paralysis would be continued. An
Yeah.
infusion form is he or she is already having.
There are
Uh,
to have the some extra you can have lidocaine infusion if there is no contraindication. You can give dexmedetomidine if possible, if it is allowed. Okay, then you can give some opiates. These are again, this is a question mark. Someone can ask you about dexmedetomidine. If the patient is hemodynamic unstable, dexmedetomidine will be a question mark. You can give a small dose of ketamine, okay, but not for, you don't need, I just caught you and you are caught easily. The patient is intubated. Why you want to give propofol or ketamine or etomidate for induction? You are not inducing the patient. You just have to maintain. So you can use some opiates. You can give some muscle relaxant. You can measure the BIS or entropy. You can use, if the blood pressure is permitting, then you will give inhalational agents. Okay. So it's a challenging, there is no fixed answer for it. But if the patient is already intubated, ventilated, you just have to, then you will receive the patient and you will do baseline ABGs. And now then the management will be continued. There is no specific answer for this thing. But one thing will be that when they deflate the stomach or the abdomen, patient can collapse. Okay. So you have to make sure you replace the fluid. Okay. And you increase the support specifically at that time. And then you can consider to give like all the organ protective strategies. You have to take care of kidneys, you have to take care of liver, you have to take care of the things going on. So you have to make sure you replace blood if needed and increase the support accordingly. So that will be a critical step when they open. Okay. And there is a concept of damage control. What will be the damage control here? Yes. They can make a
Sir,
stoma.
yes, sir. Leprostomy, not
Instead,
laparotomy. They should.
instead of end-to-end anastomosis, they can remove the extra portion, okay, and then they can make a stoma, and they can do the resection and osmosis later on. But this is not your decision. You will consider to have minimum surgery, minimum stress. So this is one option, that if they just create a stoma and instead and do the bowel resection and do the resection anastomosis later on, like anastomosis, end-to-end anastomosis later on, because there will be high chances of anastomotic leak in this scenario. If the patient is on high vasopressors, if they try to do the resection, the anastomosis, you can discuss with the surgeon. Would you like to have end-to-end anastomosis in this patient? Okay, so they can, in that thing, they remove the source of sepsis as the ischemic material is out. Maybe the gut will come back. Okay, so that is what you can discuss with the surgeon. But again, don't use closed ended sentences. You are not the surgeon. You are not the decision maker for surgical procedures. You will say, you will discuss with the surgeon, and we can discuss that you would like to do this or this, that. This word is for all questions, all discussions you are doing. Okay, so this is a patient question which they can ask a septic or any hemodynamically unstable patient coming from ICU. And actually, this domain, they can ask you the same question. The patient is going for CT scan. The patient is going for any like, for example, such patient can also come. A patient has gangrene. Okay, and the patient is now coming for amputation. So the basic care will be the same theory, same approach. Dr. Mohsen Zafar, you are writing on the screen. Please don't do it. Okay. So you will, Dr. Mohsen Zafar, you are writing on the screen. Please take care. Thank you. Yes. So amputation patient, same scenario, instead of laparotomy, amputation. Same scenario, patient is to be taken to MRI or CT scan. Okay. So the approach will be the same. If they ask, you will have the same approach. You will start from high risk. Okay. And at the same time, we can discuss another ICU topic, which is ICU transfer. Okay. ICU transfer. Just a second. make studies your friend. If you are not making study your friend, it will hurt you a lot. Okay. So ICU transfer or inter hospital transfer or intra hospital transfer. Okay. Difficult parts will be air transfer. But what is the basic concept of patient transfer? What things you need to take care?
Sir, it's a teamwork.
Okay. So what are the requirements?
Sir, the patient should be assessed that how much he is hemodynamically and systemically stable or
Decision.
unstable.
Decision of transfer.
And then it should be coordinated and communicated.
Yes,
It
communication
should
to the place where you are
to
taking.
where we are
They should be
making a
ready.
transfer.
Okay, two things.
Yes, sir.
Then
Uh, and then we have to take care of the patient and the staff and ourselves. So the drugs, the equipments,
equipment.
everything we have.
Equipment.
Yes, sir. We
Okay.
have to make
So
it ready.
all the emergency equipment, tube changes,
Like
cannulas,
like
fluid,
yes,
epinephrine, whatever drugs is taking with importance.
sir. Sorry.
But you want to listen that if you have a duration of 60 minutes probable, so you should have a oxygen of 120 minutes. Okay. Almost 2 to 3 times
Sir.
oxygen requirement should be there with you. Okay. Ambu bag should be there.
Yes, sir.
Okay.
Yes,
You
sir.
should have at least one or two nursing staff with you to help you out.
Yes, sir.
And what else?
Sir.
All the
Sir,
all the ICU care should be there. Okay. With reference to infection or prevention, or like you can say anything. It will be part of it. Okay.
yes, sir.
What else?
Yes, sir. Like IV line, central line, NG support. If the patient is on ventilator, then the ventilator parameters. The patient already should have been investigated. His documentations, his current parameters, the A to Z drugs we have to prepare. We have to prepare defibrillator, suction, oxygen. We have to prepare the other parameters like glucometers, like uh, probe monitoring and other all sort of equipments which we needed in OT. Those should be ready.
Yes. So this is all called as logistics. Okay. Logistics, communication, documentation, safety. This is the basics
Yes, sir.
parameters. And you should be knowing the
Yes, sir.
reason for
We
transport.
should know the
Yeah.
terrain, that the weather. Uh, yes, sir.
Okay,
The
so
route,
usually the
the
reason for
vehicle.
transfer,
Yeah.
sometimes neurosurgical patients are transferred, burn patients are transferred, trauma patient going for higher care. So these are the reasons for it. Okay. So as I told
Yes,
you,
sir.
land ambulances, air ambulances, helicopters, fixed wing aircrafts. This is
Yes.
something, but the basic thing is the same. You just have to whether it is moving the patient from pre-hospital setting to receiving hospital. This is one hospital to hospital transfer from secondary or tertiary care to a national care hospital, and then actually the patient taking for the any procedure in other is also part of, you can say, it is intra hospital uh,
Transport.
transportation. Okay,
Transport.
so
Yes, sir.
same things will be there: airway, breathing, circulation. Okay, and lines,
Yes, sir.
medications, care requiring. Yes, you'll see this was the what I was trying to tell you. Uh, High dependency care requiring nurse to patient ratio 0.5 to 1. Do you know what is 0.5 to 1? And you get two nurses.
Point five. Then what does 0.5 mean, sir?
I think one nurse for two patients. Okay, intensive care requiring nurse to patient ratio 1:1. Intensive care, actually,
Yes.
this is no, this is not a very good thing. Usually, if it is, this is not a good source. Anyways, so this is the same temperature, airway. You see, you can just have a look
Yes.
here. Airway, breathing, circulation, drugs, extra like monitoring, photocopy of notes. Now everything is now on the system. So if they are everything in the computerized form, so they can access it from there, or you can have a like documentation in a CD or in a USB. You can say like this. So proper documentation and mobiles, equipment. So actually, this is the basic. If they ask you this question, this you will pass. Okay. And they are also talking about the physiological effects of transfer. So actually, this is this is something difficult. Acceleration, deceleration things. Uh,
Yes, sir.
I'm not very good in this part. Anyone knows about it?
What, sir? I'm not seeing it. I'm driving. Do you mean acceleration, deceleration?
Yes,
Are
during
you
the
asking
transfer.
about that?
Yes, during the
Sir, yes, sir. During the transfer, like we talked earlier, that by road transfer, by air transfer, and by road actually happens the acceleration and deceleration mechanism of injury, which could increase the already injured patient further, which would increase the injuries. With
yes.
acceleration means when the patient is the vehicle is moving fast, then the patient physiology doesn't remain static when like the patient is staying in ICU. So with that ICP,
Like any, it can affect on any system. So
mechanical
actually,
injuries increases.
I have not read this topic before, but actually I can understand here when there is acceleration, the acceleration is toward this direction,
Yeah.
in this direction, and inertial
Yes.
forces in on the opposite direction. So it is, and
Opposite
similarly, when
direction.
there is deceleration, the inertial force is on the opposite direction. Okay. So towards the
Yes.
patient feet and displacement of blood would be towards the head. The braking force of an
Yes.
ambulance is much greater than its acceleration force, and as such, deceleration has a greater impact on a patient than acceleration. Okay. So this is a very good
Agree.
thing. Uh, Blood will pool in the feet, resulting in decreased venous return and cardiac output, causing hypotension. Baroreceptor will
Opposite
perform.
direction.
Hypotension can lead to reduced cerebral perfusion. Okay, this is the effects of acceleration. And with deceleration, what will happen? Venous return will be increased due to inertial forces pushing blood in the cephalic direction towards the head. In patient with cardiac impairment, the increased volume in the right ventricle can lead to cardiac failure or pulmonary edema. Very good. Okay, so this is something which I think this is a relatively newer tutorial. I think I have not read about it. Uh, this was after I passed the exam. So, but this is very interesting. So, effect of acceleration or deceleration. So, due to the deceleration is more dangerous. So, deceleration due to displacement of venous blood and CSF, the ICPs are increased. This is important in patients who already have ICP, high ICP. Okay. Gastrointestinal displaces the stomach towards the patient head. This can increase the risk of aspiration. This upward displacement of viscera can also increase diaphragmatic pressure and cause their smaller tidal volumes. So, I'm just thinking maybe they can reverse it by the changing the head direction. I'm not sure. They can do it in the opposite direction if the patient has any problem in the head. Anyways, so temperature, duration, physiological effects of air transfer. So it will be related to atmospheric pressure will be low on high height. So there will be chances of hypoxia. And then uh, if a critically become hypoxic during flight, this can be treated with either an increase in inspired oxygen or by increasing the partial pressure of oxygen by reducing the altitude of flight or pressing the cabin to a lower altitude. I think this topic you should read. I'm not very good in this topic, but I will highly recommend you to read about it. This is there in the patient transfer. Okay. I will not waste time because we have to touch so many topics. Okay, so up till now, we have covered some important points with reference to ICU care. Uh, we will go into the details of some of the topics. What is ARDS?
Sir, ARDS is acute diffuse inflammatory lung injury in which there is increased vascular permeability, increased lung weight, increased venous admixture, leading to hypoxia, bilateral radiological infiltrates, and decreased lung compliance.
Okay, so actually, this is an inflammatory acute diffuse
Disorder.
inflammatory lung injury. Okay, and then there is
Yes,
vascular
sir.
permeability is increased, and lung weight. This is theoretical, but usually what happens, this is acute in onset, like within 7 days, and
Yes,
degree
sir.
of hypoxia with PF ratio. PF ratio
Yes,
is,
sir.
if it is less than 100, it
Bacteria.
is severe, 100 to 200 moderate, and it's less than 300, so it is mild. And then there is bilateral lung infiltrates, whether on chest X-ray or CT. This was the Berlin change which they did, because before they also used to have the involvement of echo for pulmonary pressures. So then they removed it because a patient with heart failure can develop ARDS. So it was difficult to differentiate. So that's why they remove it. So there is bilateral radiological opacities. And because of inflammatory changes in the lungs, leading to high permeability and VQ mismatch occur. So this is the basic understanding of what, because when there will be vascular permeability will be increases, there will be area of dead space or reduced lung compliance. So that is the reason we are taking care of the airway pressures. So there is one barotrauma, volutrauma, and biotrauma. Okay. So in ARDS, barotrauma can also occur, but actually there is biotrauma. What is biotrauma? Biotrauma is through the release of these cytokines, okay? Tumor necrotic factor alpha, interleukins, okay? So, and then there is inflammatory markers which are doing to alveolar and capillary endothelium inoculation of protein-rich inflammatory exudate. So actually, this is what is called as biotrauma, okay? So the journal, what will be the causes? The next question they will ask you, what are the causes or disposing factors? So there are pulmonary
Sir,
causes and
causes
extra.
are pulmonary, extra pulmonary,
Okay. So
and
pulmonary causes
pulmonary.
this aspiration or contusion, inhalational injury, vasculitis, near drowning, and extra pulmonary is sepsis anywhere, massive
Yes,
blood transfusion, okay,
yes,
burns. So you should know that, because you should know what question they are asking you. They will ask the question in the same way. What is ARDS? What is the pathophysiology? What is the diagnostic criteria? Okay. What are the factors which can lead to ARDS? And then they will ask you for the management. Okay. So the mainly the rest of the things will be, if there is sepsis, you will treat sepsis in the sepsis way, which we have discussed. With reference to lung protective strategies, they will initially start, they will first of all, they will take the predicted body weight. Okay. Because do you know what's the concept of predicted body weight?
sir, I
Why
think
they
there is a
take,
formula for it.
no,
Uh, uh,
forget about formula. What is the rationale of predicted body weight?
uh, Sir, there is a little bit difference actually. I'm forgetting the predicted body weight.
Actually, it is
Though
with
ideal
reference to the
body weight is
development of
also,
lungs. Development of the lungs. Okay. So development of lungs, like the alveoli and everything, this is not much related to the weight. This is related to the development. Okay. So that's why they take a different formula for the measurement of predicted body weight. Okay. So formula we will find somewhere here. Okay. So anyways, so this is the predicted body weight. So then what they do, they take a low 4 to 6. So they will start at 4, and then they will take care of the pressures. They will take care of the pH, and then they will gradually increase the PEEP, gradually increase the volume. If the pressures are reached, they will not cross the pressure, and they will have permitted hypercapnia. So this is the concept. They will start at the lower tidal volumes, and they will take care of plateau pressures. They will try to have minimum FiO2, and then gradually increase FiO2 to achieve a saturation of around 92 to 94. And if they are increasing the volume and pressures are still in the limit, they will try to get it around 6 ml per kg. If it is the pressures are achieving, they will reduce the volume. They may increase the rate, and they will not cross the plateau pressures more than 30. So that is, and then with the PEEP, what will happen? PEEP can have effect on, is any effect on the blood pressure?
Yes, it can. Might decrease the blood
Sorry,
might decrease blood pressure.
your
Decrease
voice
again.
is very, we cannot hear you, unfortunately. Actually, if the cardiac functions are good, PEEP can have some good effect as well. But generally, what happens that people decrease the venous return. Okay, so they have to um, take a like balance. So then prone position ventilation. What is the rationale of prone position? Why we do intermittent proning? Yes, yes, Safullah.
Sir, equal
Sir, does the
equal distribution of ventilation
ventilation
perfusion.
perfusion improve?
1%, please. Safullah, speak out.
Sir, ventilation perfusion improve equally. The distribution of the perfusion changes, and then the ventilation of the posterior surface of the body, they also improve.
It is just like
So,
when we fry something on the pan. We are frying on the one side and then we are reverting to the other side. So it is just like that. So intermittent proning will improve the VQ mismatch by making decreasing the VQ in the area of the lungs which are not aerated in one go. Okay, so that is the main concept. So there are a number of postulated physiological benefits: improved recruitment of atelectated dorsal, leading to its improved compliance. Okay, more even distribution of tidal volume and improved VQ. Prone ventilation also decreases alveolar hyperinflation, reduces cardiac compression of the underlying lung, and improves drainage of secretions. This experimental evidence suggesting it may influence the generation and evolution of ventilator-suite lung injury. So this is another thing. Inverse ratio, in which they usually the expiratory time is less. Here, because the lungs are not ventilated, so they increase the ventilatory time. So maybe it can go to 2:1. Okay. Then there is role of high frequency oscillatory ventilation. This is also somehow help it because it will improve the oxygenation. Then recruitment maneuvers. Then the last one is thing which will be ECMO and nitric oxide. Okay, inhaled nitric oxide, inhaled prostacyclins, conservative fluid management, neuromuscular blockade if needed. Corticosteroids, they have role in the fibroproliferatic stage when the fibrosis is occurring. There it is for prevention of fibrosis. And recruitment maneuvers, what they do? Sustain inflation, continuous positive airway pressure of 30 to 40 or 30 to 40 seconds. Stepwise increase in peak pressures or PEEP. Extended sigh, I don't know about it, in which PEEP is incrementally increased and tidal volume incrementally decreased, aiming to keep the plateau pressure constant. This is followed by a sustained inflation at continuous positive airway pressure of 30. I'm sorry, you can read about it. I don't have good concept about it. So basic theory, they will ask about ARDS. This is the like they will be asking the main points. Okay, what is VAP? What is ventilator associated pneumonia?
Sir, it is the pneumonia which occur after 48 to 72 hours of mechanical ventilation.
Or this is complete definition or cessation. It can occur after even cessation. No?
Not cessation, mechanical ventilation, sir. After initiation of mechanical ventilation.
Yes, you are right. But for example, even ventilator associated pneumonia can occur later on as well. That patient remain on ventilator, you extubate it, and after some time there is pneumonia.
Yes,
Isn't
sir.
that part of ventilator? Sorry?
Actually, sir, that could be then the late onset wave. We actually divide it into early wave and late wave. Though you are right, it could be after extubation as well, but the time duration specify its types like early wave and late onset wave. When it is
Okay.
when it occur less than 96 hours, then it's called early wave. When it
And
occur
what are
after
the
96
organism?
hours,
Because they will ask you what are the organism for early VAP, what are the organism for
sir, Streptococcus pneumonia, Streptococcus pneumonia, Haemophilus influenza
this is for early.
are the most
Okay.
common.
And for
Sir,
late,
late
it's Pseudomonas,
for late onset,
Pseudomonas,
Pseudomonas methicillin resistant.
and they are
Yes, sir.
multi drug resistant. Okay. Okay, so what is the
Yes,
pathophysiology actually? The presence of endotracheal tube or tracheostomy, both of which interfere with the normal anatomy and physiology of respiratory tract, specifically the functional mechanism involved in secretion, clearing the secretions, cough and
yes,
mucociliary action. Okay, so intubated patient at reduced level of consciousness that impair voluntary clearance of secretions, which may pool in the oropharynx, leads to microaspiration
yes,
and
sir.
macroaspiration of contaminated oropharyngeal secretion that are rich in harmful pathogens. So that's why one of the reason of preventing it is good oral hygiene. Okay, and then supraglottic suctioning. Normal oral flora start to proliferate and are able to pass along the tracheal tube, forming an antibacterial, antibiotic resistant biofilm, which eventually reach the lower airways. Critically unwell patients exhibit an impaired ability to mount an immune response to these pathogens, leading to development of a pneumonia. Okay, so it's the oral mucosa, oral flora, which is usually the cause. The presence of additional predisposing factors, such as like if any other predisposing factors like increasing age,
Uh,
chronic lung disease,
age,
aspiration,
chronic,
test
like,
for upper
yes, sir.
abdominal surgery, previous antibiotic resistance, reintubation after unsuccessful extubation. This is another important point. ARDS. ARDS can lead to VAP. VAP can lead to ARDS. So these are friends. And then they can go in sepsis and they can go in multi-organ failure. Frequent ventilator circuit changes, polytrauma patients, prolonged paralysis. So these are the things which can lead to. So they will ask you what is VAP, then uh, what is early onset, late onset, bacteria, and how will you prevent? So what there are various strategies. Okay, so uh, head up. Okay, then supraglottic stress ulcer prophylaxis. Okay, then what else? Supraglottic suctioning. Then what else?
Sir,
Decontamination of
daily
digestive tract. Huh?
daily
Daily
sedation
sedation
breaks should be
sedation
given.
break as well, and oral
Yes,
decontamination. You do it. Supraglottic
yes.
suctioning. What else? Multi. This is
Sir,
another
stomach
chart.
opening,
This
uh,
is for multi-drug resistant VAP. Septic shock at
yeah,
time of VAP. Intravenous antibiotic used within previous 90 days. ARDS preceding the development of VAP. Okay. If ARDS is there and now VAP occur, this is have poor prognosis. More than 5 days of hospitalization prior to the development of VAP. Patient requiring acute renal replacement therapy prior to development of VAP. These are some data. And another important thing, remember one thing that they can ask you another definition: hospital acquired pneumonia. So hospital acquired pneumonia, community acquired pneumonia. You just have to tell any pneumonia developing in the hospital is hospital acquired pneumonia. Okay. Mm, what else? Oral care, silver coated endotracheal tubes. Okay. Result for reducing the relative risk of and bundle, reducing aspiration, nurse in a semi-recumbent position. One more thing, it maybe it will return. If you are giving enteral nutrition, better to give in infusion rather than bolus. Okay, this is also something for prevention. Let's see it is written here or not. Avoid unnecessary endotracheal tube change, subglottic suction. I've maintain tracheal tube pressure, cuff more than 20. Why this is important? It will sort of prevention of aspiration. Stress ulcer, oral hygiene, infection control, this hand hygiene, unnecessary circuit change, daily sedation breaks, daily assessment for extubation, monitor VAP rates, local input for microbiology regarding this one. So they will ask you about these scores. There is a one Johan's criteria. Or this is CPIS score. So in this temperature, WBC count, tracheal secretions, X-ray findings, culture, and oxygen PF ratio. On these parameters, they define this CPIS scoring system. If you don't know this data, no problem. This is not a criteria. This is not possible to remember. So focus here. Okay. Temperature, WBC count, tracheal secretions, radiological findings, culture, and PF ratio. Okay. Mm, so there is fever, there is leukopenia. Okay. Two or more serial chest X-ray, new development of new findings, and treatment, culture specific antibiotics, and then you try to avoid intubations. What about role of non-invasive ventilation? Is there any role? I think it will reduce or no, non-invasive ventilation.
Sir, it
Okay.
can help in if early need of ventilator, then we can assess the status. Can patient survive on some NIV techniques or post extubation? If there, we can early remove the tube to avoid the wave.
Okay. Okay. One, what is brain death?
Sir, it's complete cessation of sensory and conscious stimulation.
Is it a correct definition? I forgot the definition, but it is loss of consciousness as well as loss of inhibited. Just a second. Can anyone improve the definition for brain death? Yes. I think it is irreversible ability to breathe as well as inability to have the this brain function. So that this is permanent, irreversible, and complete loss of brain function, which may include cessation of involuntary activity necessary to sustain life. I forgot there was a specific definition written somewhere because that is an old article. I think that from where I read. Uh, Anyways, how to identify brain death? Yes.
We can check reflexes, sir,
What reflexes?
like pupillary, corneal,
Okay.
oculo, vestibular, gag reflex,
We check all the
ap- apnea
uh,
test.
no, we do all we check all the cranial nerves separately. Okay. Just a second. Okay, so before we check what we do, there is some precondition. The pathology of irreversible brain damage must be identifiable. The patient must be unresponsive. There must be no consideration that the patient has any sedative drugs or hypothermia or reversible circulatory, metabolic, or endocrine disturbances. Okay. Deviations from normal may occur, and the diagnosis is not precluded if these disturbances are consequences rather than the cause of neurological dysfunction. The patient must be apneic, requiring mechanical ventilation. Okay. Neuromuscular blocking should be reversed by peripheral nerve stimulator or by eliciting deep tendon reflexes. Effects of narcotic or hypnotic must be excluded or reversed. Okay. So now what they do, pupils are fixed with no direct or consensual light response. They are checking 2, 3, and then parasympathetic outflow. It is not essential that the pupil may be maximally dilated or equal in size. There is no corneal reflex, no conjunctival reflex, okay, and no motor response within the cranial nerve distribution in response to marked mechanical stimulation of any somatic area, okay, and no limb response to a supraorbital pressure, okay, in the form of music, and vestibulocochlear nerve by what we did this caloric test by this cold water injection. So the tympanic membrane should first be visualized, any wax or debris removed. That is flexed to 30 degrees for the test, and at least 50 ml of ice water is instilled over 1 minute deep into each external auditory meatus. The eyelids are held open to observe any eye movement, principally nystagmus, during or after the installation of water. If the performance of these tests on one side is impossible because of local injury, are not invalidated. Okay. There should be no gag reflex. 9, 10 loves are checking, and no cuff or other reflexes to passage of a suction catheter down to the endotracheal tube or stimulation of carina. Then they do the apnea test. So no respiratory movements, and then what they do, they correct, they give oxygen. The patient when the patient is disconnected from the ventilator with chest and abdomen exposed, the patient should be pre-oxygenated and the PSU2 allowed to rise up to 40 prior to disconnection from the ventilator. Hypoxia should be prevented by oxygen insufflation through a catheter within the endotracheal tube. Sufficient time should be allowed for PSU2 to rise to above, and if there is no stimulation of respiration, it is confirmed. Okay, and also they do it by doing ABGs. Usually, it should be done by two consultants or one consultant at two different times before labeling it. Okay. And then if this patient is going for organ donation, because they asked me this question was asked. You see, that's how we forget the things. This question was asked to me in FCI Irish Fellowship exam. that you have a cardiac arrest outside. How will you manage? And then they bring the patient to ICU, and then they ask me about brain death, and then they ask me about organ donation. So in that you have to maintain the ventilation, you have to maintain the vital organ perfusion, okay, and then this is what you say, heart is beating, but brain is dead. So brain dead organ donor, okay. So in there, they need to give desmopressin, T3, and steroids, and then they also maintain the ABGs, the electrolytes, the blood pressure. So they um, do it, okay. Okay, so I think I will stop here. We have some more topics we will try to cover in our next session: delirium, uh, then acute pancreatitis, and ICU muscle weakness. Okay, so thank you very much. Inshallah, we will meet again. Actually,
Sir, can you share these articles in the WhatsApp group?
very good. You are not in the group,
Sir, I am in the group.
and so please wake up and see the in the description. These links are there. Open it. You will find everything in the description. You will find this article link. All articles are there. Okay. Okay, Vakar.
Right, sir. Once I tried to find, but I was unable, sir.
Why? Okay, just drop a message to me in person and I will send you. Okay. So thank you very
Thank
much.
you.
And inshallah, tomorrow in the night, because today I was off. So that's why I took it at this time. So tomorrow, most probably around 10:15, 10:20 night, we will have our discussion of Pakistan time. Okay. So thank you very much for coming. And please read the topic, because unfortunately, I give you the purpose of our discussion today. I give you a brief overview of ICU management. We discuss about some points about ICU transfer, sepsis, VAP, ARDS, nutrition, and general care of ICU patient. Because the individual topics, even like for example GB syndrome. If you read about GB syndrome, only the few things will be of GB syndrome, that how developed, there is preceding gastrointestinal or respiratory tract infection, and then the antibodies, there is ascending motor paralysis. There are different types, and then what happens? Nothing specific, only they do this plasmapheresis or steroids, and the rest of the nursing care is the same is true for anything like um, so that's why it's very important. I wanted to discuss weaning, unfortunately just slipped out of my mind. So tomorrow inshallah we will try to discuss about weaning with this critical illness, neuropathy, how we predispose the patient. We will discuss delirium and acute pancreatitis. Okay. So, but I tell you something, the journal questions and journal care is more important. So focus on that one. Okay. So thank you very much. Bye bye.